Good evening and welcome to one and all. I'm Shashank from Planet, the designated session assistant for a seamless experience from Planet. Planet is India's most trusted and widely used digitech platform with multiple enriching services exclusive for doctors. Planet is very proud to be a digital partner for this event organized by Indian Academy of Pediatric Gujarat. And topic of today's session is case presentation fever with hepatomas. Let's begin today's session, for which I would like to invite to Dr. Nehal Patel. Ma'am, please take over.
Thank you, Sashank, and thank you, Clarinet, for providing this platform. And I welcome all of you to E-Gurukul Pathshala PG Clinic. Today, we have a case discussion on fever with hepatosplenomegaly. And for this, we have a presenter, two presenters, Dr. Mansi Bhavsar and Dr. Dhruvi Damsania. I must welcome their mentor, Dr. Namrata Makwana. She is an associate professor in the Department of Pediatrics at the MP Shah Medical College, Jamnagar. We have three experts this time, those who are stalwarts in this field, and I welcome all the experts. So I welcome Dr. S. Srinivasan, sir. Sir is former director, professor, and head of Department of Pediatrics at JIPMER, Pondicherry. He is adjunct professor, academic part, in the Department of Pediatrics at Mehta Super Speciality Hospital and PG Training Institute at Chetpet, Chennai. He has many publications like Nationals 110 and International 30. He has delivered 16 orations, which is a moment of pride. He is examiner for MBBS, MD, and all the types of exams we can give for our pediatrics. So welcome, sir. We have our second expert, Dr. Abhay Shah, sir, who has received gold medal for his MBBS and MD, and he was university first in diploma, and he is FIP also. He is a director of Children's Hospital and Pediatric Infectious Disease Center at Maninagar, Ahmedabad. He is member of ACVIP in 2021 and 2018-19. He is National Scientific Convener of IAP Action Plan in 2021. He is chairperson of Infectious Disease Chapter of IAP in 2015. He is recipient of Dr. Tapan Kumar Ghosh Memorial Oration in 2021 and Dr. Shivnanda Oration in 2015. He has many publications and book chapters, and he is on editorial board of reputed textbooks like IAP Textbook of Pediatrics, Textbook of Pediatric Infectious Disease, IAP Textbook of Vaccines, IAP Guidelines on Immunization, and so many, around more than 15. So welcome, sir.
Thank you so much. Yeah.
I also welcome our third expert, Dr. Rajendra Khatke, sir, who is consultant pediatrician, and he is owner and director of the Varad Medical Foundation, Aurangabad. He is practicing since last 30 years, pioneer in the pediatric critical care in Marathwada region, and faculty of National Pedicon 2018 with National Faculty of Immunization Module, faculty of West Zone Infectious Conference 2018, faculty in Mahapedicon State Conference, and is course coordinator of immunization module developed by IIP Aurangabad. He is faculty in multiple regional, state, and national online conferences. Welcome, sir. We also have today our project in charge of this, Dr. Yogesh and Parikh. Sir, a few words from you.
So first of all, welcome to all the dignitaries, Dr. Srinivasan sir, Dr. Raju Khatke sir, Dr. Abhay bhai, and welcome our convener of the E-Gurukul Pathshala, Dr. Baldev Prajapati sir. He is mostly traveling, sir, in the car. And Dr. Aarti Kinikar madam, Dr. Nehal Patel madam, our project coordinator. And I am proud to see my college alumni, Dr. Mansi and Dr. Dhruvi, presenting the case today on the fever with the hepatosplenomegaly. Mansi and Dhruvi, હું જામનગરની જ પ્રોડક્ટ છું. and Dr. Dhaval is also there. So we are. Let us start the program because we have almost 10 minutes late. So let us start the program. Baldev Prajapati sir will join after reaching the hotel. He reached, means he's in the car. Sir, unmute. Prajapati sir, unmute. Sorry,
I think he has problem in unmuting. Yeah.
Yeah,
So-
he's in the car.
So Mansi and Dhruvi, you people can start sharing the case, and whenever our experts requires, you can stop and then take part in the discussion. Sir, now the platform is all yours till Baldev sir joins. Please let the discussion go ahead with all the experts.
Thank
Yes,
you, madam.
okay, thank you.
So Mansi, Dhruvi, please start sharing your screen.
First, yes, ma'am. First, we'll start with the presentation, ma'am.
Yes, PPT, start PPT. PPT of case presentation.
Share the screen.
Yeah. Make it full.
Yes, sir.
Yeah, good. Full screen. Good. It has come. Yeah, you can start.
પૂછી લો પેલા તો ફરફર ના કરવો પડે ફરવું નહીં પડે અને ખબર જ ના હોય ક્યાં જવાનું તેના કરતા પૂછી લો
Sir, Baldev sir, away unmute.
Yes,
karo.
sir.
Yeah.
Sir, can we start?
Yeah.
Good
now
evening,
you
sir.
are live.
Good evening, sir. I'm really
Dr.
extremely
Baldev
sorry,
is
but
my teacher.
now for sorry, sir. I am now focused to the discussion. No problem.
Yeah,
Yes, sir. Yes, sir.
we can start.
Yeah.
WhatsApp છે બાજુમાં જે કેનો
Some crosstalk is there. I think it
Yeah,
can be muted.
driver is talking, sir. Driver is talking.
હા કેટ ઓફ ક્લબ કરીને
Yeah. Okay. Go ahead, please.
Can we start?
Doctor.
Sir, can we
Yeah,
start?
ready.
Yeah, please.
Yeah,
Dr.
ready,
Mansi.
madam.
So myself, Dr. Mansi Pau, sir, and so myself, Dr. Dhruvi Damsania. We are second year resident at MP Shah Medical College Pediatric Department.
Sir, we are presenting case on fever with hepatosplenomegaly under guidance of Dr. Namrata Makwana, assistant professor of our MC Shah Medical College.
If you don't mind, I want to react here. Can I do it? So don't say case. We are not lawyers. I am presenting a child of this age with the okay. Actually, Hutchison's quotation is never treat a patient as a case. So when you present, you say I am presenting a child whose age is or a boy or whatever it is. So that case, I am presenting a case that looks a little odd for me. Of course, I am
Yeah,
sure others will agree with me. Yeah.
Yes, yes.
Okay, sir.
We should not reveal the diagnosis in the present, in the starting.
Yeah.
Informant is mother, who is reliable. 5 years, 4 months old male child named Pavitra, resident of Garid, birth of non-contiguous marriage, by caste Barwad, presented with our GG hospital Jamnagar with a chief complaint of fever and cold since 2 days and swelling below bilateral ear since 2 days, abdominal distension since 2 days and throat pain since 1 day. Child was asymptomatic before 2 days of admission, and then he started a fever, 2 to 3 high-grade fever spike per day, which was and relieved by medication. Fever was without chills or rigor, and child was sick in interfebrile period. There is also complaint of swelling below bilateral ear since 2 days, which was gradually increased in size and not associated with pain, redness, or discharge. And is also complaint of abdominal distension since 2 days, which was associated with fullness and discomfort in left upper abdomen. And there was
Please
also
stop,
complaint of
beta. Please stop, beta. Go to the first slide. Go slowly. We should also understand what you are talking. Please go to the first slide.
Each and every slide you tell what is your this thing. Crystallized information from each slide. That will be nice. What are the points you think? Yeah, logically you think, and then yeah, good. Proceed.
So this is the child with fever and cold for 2 days and swelling below the bilateral ear for 2 days, and there is a progressive abdominal distension since 2 days. So the history is very short.
Yeah. So fever and cold gives what? Rings which bell in your mind? Fever and cold. Can you hear me?
Infectious origin.
Yes, sir.
Okay. Infection. What type of infection when the cold is there?
So an
Among-
upper respiratory tract infection.
Okay. Upper respiratory, viral, bacterial.
Viral bacteria.
So mostly it can be viral because
Yeah. So most probably viral. Okay, that is the first thing. Next, swelling below bilateral ear for 2 days. So what type of swelling you think bilaterally present after cold in a viral condition? So are they lymph nodes or
Sir,
some other swelling?
Sir, it was like a lymphadenopathy because of
Is it periauricular or it is in the neck?
No, sir. It was in anterior cervical region, below anterior cervical region in front of sternocleidomastoidoma.
So if you are saying in the neck, why do you say that basically it is just below the bilateral ear for 2 days? Because if you talk about anything near the ear, you always think about parotid glands to be involved. No?
Absolutely, yeah.
So,
So,
so you want to say that basically there is some swelling which is in the anterior part of the neck.
neck, yeah.
Okay.
Then abdominal distension.
That is
Abdominal distension, which was associated with some discomfort in the left side upper region of abdomen. And
see now the story goes only for 2 days and all these symptoms evolve in 2 days, right from your fever, your cold,
yes,
your lymph nodes, your slow abdominal distension and throat pain for last 1 day. Now, is it that acute that basically these 2 days have given rise to all these symptoms, or there is a progression of the symptoms over a period of time?
no, sir. Symptoms were present only since 2 days. Sir, swelling which was gradually increased only since 2 days. Before 2 days, child was absolutely asymptomatic.
Good. That, of course, you could have mentioned in the beginning itself. A child who has been previously normal, otherwise, according to the mother, has presented with acute symptoms of this thing, fever, cold, and evolved with other symptoms. Good. Yeah. Shall we proceed to the next slide, sir?
Yes.
So fever was 2 to 3 spikes per day, which was high grade in nature, and so intermittent, and fever was relieved by medication. So fever was without chills or rigor, and child was also sick in interfebrile period. So swelling was present, which was gradually below anterior neck region, which was gradually increased in size and not associated with pain, redness, or any discharge, and overlying skin also normal.
Just wait.
And also abdominal
Just wait on that slide, no?
Yeah. Yeah, proceed.
So what is the fever pattern indicates? What type of fever it is? When the child is 2 to 3 spikes a day, intermittent, relieved by medication, sick in interference region. So how does the pattern of fever helps you? What conclusion would you like to make this?
So child was sick in interfebrile period, so it can be bacterial in origin. And sir, 2 to 3 spikes per day,
So it was a intermittent type of fever, which touches baseline, after fever spike.
So how will the fever pattern in viral, in bacterial, and in immune-mediated fever? What can be different types of fever patterns?
So fever is intermittent, so it can favor viral in nature, but child is sick in interfebrile period, so it can be bacterial.
So very high grade fever to start with, and then response or getting recovered by day 4 or 5, usually viral. If it's a bacterial, usually the fever is mild to moderate and picks up, and during interfebrile child is toxic, and response to paracetamol is not that great. And what about the immune-mediated fever? Yes, sir. Yes, please.
Can I ask a question?
Yeah.
You mentioned relief by medication. So naturally, the medication is after consultation with the doctor or self-medication by mother or parents. It's very important because, spikes will be, if the child responds to paracetamol or whatever medical drug has been given for fever. So then, of course, the importance of the spike of fever, only thing it will mention that it is responsive to pyretic medication. Okay, but you have to ask whether it has been given self-medication by parents or after a consultation from a doctor. That will give how soon they have approached the doctor, medical help. Okay, so that information you can add because, many times self-medication. So the spikes of fever may be because of the response to the drug or it may not be there, but you have mentioned very specifically sick in interfebrile period. Okay, that means child hasn't become totally normal in between the fever episodes. So child has something a little more serious than what we think. Am I correct, Dr. Abhisha?
Yes, sir. Yes, sir. Yeah, please.
So
Okay,
what do you really mean by sick in between the 2 episodes of fever? Was the child cranky? Was the child not feeding well? Was the child apathetic?
Okay, exactly. You have to little more details. You have to mention that.
Child not taking orally well since in between fever spike, and child was mostly lie down on bed and not
Active.
not active.
Yeah, less active and mostly lying down. Okay, apathetic. Good. So you have answered the question. Yes. So child was not totally normal in between the otherwise, so many viral fevers after the fever comes down, they'll be playing and they'll be this thing. But this child was lying down. That means child was a little more sick than what usually is. Yes, good.
Yeah.
Next.
So can I proceed to next slide?
Yes, please go ahead.
Swelling, of course, you can ask a little more detail about the mother because, how it's a peanut type of size, it's significant swelling or whether she felt it or whether she could see it, mother. Okay. So because, many times they find something abnormal in the neck and they feel it and they'll be able to say what is the size, you can give an idea from the history from the mother, what is the size. Okay. And whether it's multiple feeling, of peanut type of this thing in the neck, and you mentioned the area already in answer to question by Dr. Katke. Yes, proceed. Yeah.
Here the fever also has to be described properly, whether that fever has been only intermittent, remittent, or whether it is quotidian, what type of fever, and what was the response to the antipyretic.
Because it was only 2 days, probably they thought it hasn't gone to a longer period to give a definitive answer to your question, sir.
Right.
Yeah.
Next slide.
Sir, child has also complained of throat pain since one day, which was associated with difficulty in swallowing. So child was admitted and medication was started, and gradually fever spike decreased, and child was afebrile on third day of admission. So abdominal distension also started to decrease, and child also started to take orally on day of admission too only. And sir, neck swelling also started to reduce on day of admission.
So here you say that abdominal distension on since 2
So
days.
child is
1 minute.
No,
1
you
minute.
go to the
So,
previous slide, yeah.
so the
You
abdomen is
interpret. Yeah.
now 2 days. So there is an acute distension of abdomen, right? So what possibly comes in the mind when there is an
No,
acute
she has
abdomen?
mentioned specifically left side.
And
Left
there is
upper
fullness and
abdomen.
dyspnea left upper abdomen. So how will you justify this statement?
Left upper abdomen, what are the organs which are there? So stomach is there, then of course spleen is there. So what is your interpretation? Is it gastritis with fullness and flatulence and discomfort, or you think it's some other problem? Left upper abdomen, how do you interpret? See, I've taken a very good history, but it should give you some focus, on possibilities, because a fever, most of the viral fevers will have gastritis, especially aggravated by antipyretic medication. So you must be able to think what is, because you have localized a symptom. So that's what Dr. Abhisha wants you to interpret. What happened to you?
Are they only these two presenters or some other students are there?
Sir, right now it is only two of them, sir.
Okay. I think it's a good presentation because jointly they are doing so, supporting each other.
Yeah, that's good.
I think what I will suggest that go first forget regarding the case, go for this analysis of each symptom, then come back to your patient. Then I think it will be the good so that you can learn and you can remember even so many things. Suppose already the point is there or regarding the distension of abdomen, forget regarding the left side. I think I would like to interact with these two students, two presenters. Suppose distension of abdomen, any mother complains, what other points you will ask? Forget regarding this patient, I'm again repeating, so that you understand that what is the reason for the distension of abdomen. Can you respond? What other questions you should ask regarding the distension of abdomen?
Sir, we will ask about is the child has passed a stool or
Okay.
is it associated with abdominal pain?
Or associated
Okay.
with some complaint of vomiting.
Okay. But regarding the first, I will say that is associated symptoms that you may keep the last. But before that, what other points you will ask so that you understand that which factor, which pathology, which problem is likely responsible for the distension. Suppose if I guide you, if it is due to the gaseous distension, what will be the, I will say, information from the mother will be available. Suppose if it is gaseous distension, how the mother will describe?
Will there be difference in position?
It will be generalized distension of abdomen.
Number
and,
one, it will be generalized distension. Very good. What will be the next point? What will be the duration of distension? Usually, most of the times.
Before passing the stool, child have distension.
Absolutely,
and it can be
very
reduced
good, very good. So waxing and waning, suppose if it is there, that is more favoring the gaseous distension. Usually it may be the acute, it will be generalized, and it will be
Discomfort will be positional also.
after
So it will be
passing
more while child is lying down.
the flatus
Pain.
or even the fingers. So that is number one. What suppose if it is really developing some ascites, how the patient will present or what, how will get the information? Distension due to the ascites.
It will be, sir,
What questions you will ask to the mother?
It will
Come
gradually
on.
increase in size, sir. Gradually increase in size, and
Okay.
it will change. The distension will change position with position of child. If it is mild or moderate.
Why the position will change this? I will say distension in a case of ascites. On the contrary, if I give the hints, suppose the fluid started to collected in the peritoneal cavity. Then first, where the fluid will be collected and what will develop, from which you can suspect that, yes, this is likely the fluid collection. And then you can ask the mother, there where was the distension was there from the beginning.
The left upper abdomen she had mentioned.
No, I'm not asking for these patients, generalized for the ascites. You know, the ascites, the fluid will be first in the flanks, periphery, laterally. So there will be the first lateral collection. Then with the progress of even the collection of fluid, it will come from lateral to medial and then it becomes generalized. Right? Suppose if it is due to the organomegaly, then what happens?
Sir, it will be the localized.
Organomegaly, that means suppose hepatosplenomegaly.
Then
How it will develop? You know, where the organs are located, liver and spleen, where they are located in the abdomen.
So liver, right side, and spleen.
That means upper part of the abdomen, like upper part of the abdomen.
Yes.
Organomegaly. Suppose if it is some mass, Bim's tumor or something, mesenteric, then how there will be the distension?
Sir, mass will be palpable on abdomen.
No, how distension will develop? Forget regarding the mass. You know, distension will be usually central. Right?
Yes.
If it is used one, then goes from central to periphery.
Don't think of
Ascites-
mass straight away because we don't know whether we haven't palpated. So you say
So we
only
don't
fullness
know.
and discomfort. So you have to think of all the possibilities.
So what
Fluid,
was-
gas, and some solid this thing.
So what
Okay.
was my point for distension of abdomen? How you can decide? Ask the mother what is the duration, within how much time the distension had developed, from where it started, and how it is
Positional change is
progressing.
there.
Positional changes with the suppose even waxing and waning, associated symptoms, then probably it will give you the idea that what is the likely cause of distension. The point is never first focus regarding your case. Your case probably you may be knowing. But suppose the patient and you are sitting in the OPD, patient enters with a complaint, you should know that how you should gather the information regarding distension of abdomen, from which probably you can decide that it is likely the gaseous, it is likely organomegaly, it is likely collection of fluid, or it is likely due to some localized mass or cyst or something like that. So that art you should learn that how to ask the information from the mother. You know, suppose patient comes with a huge distension, then all these points have gone. You don't know whether it was ascites or really huge ovarian cyst or really something. But how it started, then what was the progress, whether it is progressive or static, whether it is waxing or waning. So all these, I will say, adjectives you'll have to find out, and that will provide you lot many information. Just, sir, I request that I will have to now reach the hotel.
Yeah, please,
I will
please.
again join after 5-10 minutes. Please carry on. Please carry on. Thank you very much. Thank you very much.
So I appreciate you have mentioned non-specifically fullness and discomfort left upper abdomen. You have to say whether it gets relieved by positional change, because gas, when the child is having flatulence of stomach, if they lie down on the back, then it will be more. But the child slightly turns to one side or sit up. So positional change, these things, minor things you can ask from the mother, they'll be able to tell. Okay, in which position child is comfortable. Okay, yes. Now next symptom, throat pain.
Sir, throat pain was present since one day, and it was associated with difficulty in swallowing.
So what it can be?
Sir, upper respiratory tract infection or any pharyngitis.
So difficulty swallowing is common with viral or bacterial?
Viral, sir. And sorry, sir.
Like pharyngitis most commonly
With bacteria.
bacterial streptococcal pyogenes.
Yeah. So any exudative illness, localized lesion is there, you will get the dysphagia, right? Yeah.
Yes, sir. Yes, sir.
So now we have also added now, apart from cold and this thing, child is having also pharyngeal involvement. And of course, you already mentioned about the lymph nodes. Yes. proceed. Child was admitted.
So child was admitted and some medication was started. And sir, child gradually improved with gradually decrease in fever spike, and child was afebrile on third day of admission. Sir, abdominal distance also started to decrease, and child started to take orally on second day of admission, and sir, neck swelling also reduced on third day of admission.
So what is your feeling now? Now that you have mentioned specifically within 3 or 4 days, child has shown some response in all the symptoms which you have mentioned. So what do you think it's likely to be? It's not increasing or it's not static, but there is some improvement. That's what according to your information. So what would you interpret with this information?
Sir, any infective origin, which is mostly viral, because child, because of acute illness, and started to improve
But
within
if
2
you
to 3
say
days.
if you say that viral specifically, then I will ask this question because you mentioned admitted some medication given. So now, of course, most of the parents will know whether the antibiotics are given or some drug was given. So if antibiotics is given, child shows improvement, then it may not be viral. Okay, so it's important that child was admitted and some medication was given. Of course, if they are illiterate, the mother may not know what medication has been given. Okay, they cannot interpret.
And
But
in
it's very
viral illness,
important. Yeah.
in viral illnesses, the child will not be sick in between the fever.
Yes.
Any idea whether parents are educated and they knew what type of medication did they ask?
No, sir. Parents are illiterate.
Okay, fine. Okay, but
They
still,
don't know.
even illiterate parents may know. So must not assume that they don't know. Whether nowadays most of the parents may ask the doctor, sir, what are they giving? So anyhow, it's good that child has shown improvement. Okay, Dr. Abhaisha, your comments, please.
No, I think we'll go ahead because just the
Yeah.
third or fourth slide. Let's
Sure,
yeah.
sure.
All,
Okay,
all,
sure.
all,
Next.
all points have all covered now. Yeah.
Okay, next slide. Yeah.
Yeah.
So child has no complaint of difficulty in breathing, so which will rule out lower respiratory tract infection. And sir, there is no complaint of rashes or decreased urine output. The child has no complaint of rigor or chills associated with fever. And sir, there is no complaint of vomiting, abdominal pain, or yellowish discoloration of skin and sclera. There is also no complaint of weight loss, loss of appetite, or any bone pain. And there is no history of ingestion of raw milk or uncooked meat by the child.
So tell me the importance of each of that negative history. There is in a child who has got the fever, pharyngitis or tonsillopharyngitis, probably lymphadenopathy and abdominal distension. What is the significance of difficulty in breathing? So
Good information, but interpretation. Yeah.
How will you interpret this?
So there is
no respiratory LRTI, number one, right?
Yes.
Second.
So there is no history of rash or any decrease urine output, which will rule out.
No, the first one only.
So when will you expect the child is breathless, or there is some loss of weakness, or energy is not adequate? So what would you indicate? So probably one is LRTI. Second, the anemia is also not that significant, that the work of breathing is not increased. Number two, and sometimes the distension is not that troublesome, that there is a difficulty in the breathing. So, right, these three things are important in the context of our case. Then what about the rash? Yes,
even in upper airways, probably if the larynx would have been involved, probably you will have stridor and difficulty in breathing.
Yeah.
Yes.
What is the importance of rashes?
Yes.
And don't combine rashes with the decreased urine output.
Yeah.
Okay.
that's about
okay. Because we have both added together, that means it has some other significance. Rashes, why do you think? Pharyngeal infection, specifically rashes in a child with probably cervical lymphadenopathy, as you have mentioned. So what is the importance of rashes in such a
fever,
situation?
rash and lymphadenopathy.
Which condition you are probably thinking of?
Fever, rash, and dengue fever.
Dengue is rather uncommon cause of lymphadenopathy.
Yeah. Lymphadenopathy, as well as there will be more of pain, body
Oh,
pain and
pain, body pain.
headache and
So
this thing, and
for the
gastritis.
lymphadenopathy, can even EBV itself cause this fever lymphadenopathy rash?
Yes, sir.
Can scarlet
must
fever
always
cause
think
it?
of.
Yes,
Can scarlet
sir.
fever?
Other viral infection like measles and
Adenovirus,
rubella.
measles, even
Yeah.
rubella can have
Now
fever,
recently
rash. So there
adenovirus
are
was causing such a big this
adenovirus.
thing, everywhere adenovirus was causing this type of this
So-
thing, but cough was maximum. But here, of course, we haven't
Yeah.
mentioned cough as an important symptom. Yes.
So
Okay.
there can be some viral infection, there can be some bacterial infection. So viral, we have got even measles, rubella.
Scarlet.
We can have an AB virus, we can have CMV, adenovirus,
Yes.
HIV. All these can have a fever, rash, and lymphadenopathy. Amongst bacterial, which are there?
Scarlet.
Yeah, scarlet fever, the localized infection is there. Then can non-infection like Kawasaki disease have a fever, rash, and lymphadenopathy, right?
Yes.
What
So that
goes
is a-
against what goes against Kawasaki in this case?
Yeah. What is the
So
important
that-
thing which you'll look for in the face? I'm
So
giving you a clue.
conjunctive,
No. We are talking about fever. We are talking about throat pain. We are talking about bilateral lymph nodes.
Hmm.
Yeah.
And there is no rash. In Kawasaki,
Yeah.
though it is a mucocutaneous lymph node syndrome, you usually have a single group of lymph nodes which is involved.
And usually
Absolutely.
cervical.
Yeah.
And usually
And also
cervical.
conjunctivitis, redness of this thing and scarlet tongue. Of course, that is will come the examination.
And
Okay,
age of the child doesn't go in favor of Kawasaki. If it is less than 5 years, then the symptoms would have been different.
Yeah. And secondly, any serious condition can have a fever, rash, and lymphadenopathy. Any bad disease. Even leukemia or lymphoma can have a fever, rash, and lymphadenopathy, right? But where the child will
Yes.
be extremely sick. So the fever, rash, and lymphadenopathy is a very wide spectrum of differential diagnosis. Now go ahead. How about chills and rigors?
Sir, chills and rigor that to rule out malaria.
Any infection can have a fever and rigors, right? But
Yes.
so in viral,
Yes.
maybe we get often fevers with rigors and chills. Vomiting.
So vomiting, abdominal pain, and yellowish discoloration to
So what
rule
does it
out
rule out?
viral hepatitis C.
Yeah. Okay. Good. Then-
And sir, no. So there is no complaint of weight loss, loss of appetite, or bone pain, which will rule out immunocompromised state or any malignancy.
Yeah, so there's a night bony pain is a very characteristic, given history, you have to look for the malignancy. And raw milk consumption of unpasteurized milk, raw milk, what does it indicate?
Sir, there can be brucella or any toxoplasmosis infection.
Yeah.
Good.
Good. So now you have got this community of the patient is, I think, Brevard, right? So again, the likelihood that they have got this type of habit of consuming raw milk or the unpasteurized milk. So I think brucella is one you need to rule out. Yeah, please go ahead.
One point I want to make, you have mentioned no history of weight loss, loss of appetite, bone pain. Bone pain I already explained. But weight loss, you have to mention in the beginning itself, a child who is growing normally. Okay. And this thing, 5-year-old child, so naturally you have to mention, then you will know whether the child, and of course it's too acute to have weight loss.
It's
Okay,
too
no,
acute to have weight loss and loss of.
Yeah.
And
Yeah.
there has to be loss of appetite because the child is sick.
Yeah. Good. Proceed, next one.
In past history, there is no similar complaint in past,
And
or there is
one
no
minute,
other.
before that, when you narrate the history, it's in a chronology of the symptom. Like so, once you say about decrease in output, then you say about the vomiting, then you say about distension. No, so abdominal symptom
Should
एक
come
ग्रुप
here,
बनाओ,
all
रेस्पिरेटरी
together.
का एक ग्रुप बनाओ, ऐसे बनाओ, ठीक है?
You group them together. When you are talking about abdominal distension, all
Once
these
you-
symptoms should have been mentioned.
Once you say about the breathing, then you go to the urine output, it's not good. So you have to step by step, all one system pertaining symptoms will be grouped in a one group. So place in a one group. Yeah.
You understand the importance of it. So just group it so that you'll have a
It looks
more
good, eh?
precise understanding. Yeah, we are improving your presenting quality of presentation, not that you are doing badly. Okay, these suggestions are for improving you in another 1 year. This is your second year. So definitely
Yes,
you can make differences in your presentation and impress the examiners and get marks, pass marks only from the history. Yes. Am I correct, Dr. Shah and Dr.
Yeah,
Raj
yeah.
Khadke? Yeah.
Yes,
Yeah.
sir.
Because once you present a history, you'll be able to give 60%, 40 to 60% diagnosis, as well as 40 to 60% of marks you can get in the examination, because they know that you have been regularly presenting cases in the wards. Yes. Proceed. Yeah.
So in past history, there is no similar complaint in past or no other significant past history of admission. So in family, the patient belongs to nuclear family with 6 family members. He is living in Kacha house with 1 room and kitchen with separate toilet. And sir, water supplies corporation, mother and father both are illiterate. Sir, patient belong to lower socioeconomical class according to modified Kupuswamy classification. And there is no family history of TB or allergy in family and no similar illness in family.
Yeah,
So
you are
child is
mentioning. Yeah. Can I make a comment? Yeah. You have to mention about family history, but before that, growth and development of the child is important, the history. So 5 years child, you should have mentioned at least 2 sentences about a child who has been, what is the birth weight and how the child has, this, because growth and development is very important. That will tell whether the child has been growing well nutritionally, as well as some other problem was there, chronic problem which is presented acutely. So you have to emphasize, okay, because nowadays, Anganwadi workers and others are doing very good work in the field, and they are plotting the mother infant, they saying no card, and they tell them. So you must always mention growth and development is part of a growing child. So you must always mention before so many families and other things whether the child growth and development has been normal till now, because this is an acute problem. You have mentioned no diseases, no problems. Okay. If you add those 2 information, that means we know that child has been having no problem earlier. Am I correct, Dr. Abhaisha and
Yeah.
Raju?
Yes.
Khadke?
Yes.
Yes, sir. Yes.
Because in
Yes.
the history should mention, because parents are always concerned about growth and development, they will be able to say, when compared to other children, because the child, the mother is having so many children. So they'll be comparing each and every child's growth. So they'll be able to give this information. That will give whether it's an acute problem or a child has been having something quiet and suddenly it has presented as symptoms. Okay, thank you.
Go ahead, please.
In birth, the child is a full term, born with one full term normal vaginal delivery, and birth weight was 2.7 kg and cry immediate after birth. No history of NICU history was present, and sir, child was immunized up to 1.5 year of age. And sir, vaccination detail as per Mamta card. In diet history, sir, child was
1 minute. So go ahead, go previous slide. So in this is given in the Mamta card, right? So which type of the polio injectable vaccine they give? By which route? IPV
Oral.
given. Oral to hai, IPV by what dose?
0.8 fractionated IPV.
Yeah, so it is intradermal fractional IPV, right? Yeah, and 1/5 of the intramuscular. So this small thing is very important. They can ask you in the question exam. Yeah.
Yes.
Please go ahead. Yeah. In 1 minute. At 9 months measles, so they give measles or MR?
MR.
So standalone measles is no more available in India. So these small things are very, very important. Otherwise, the discussion will go on the other track and our case will remain on the other side.
It is
So
a
we have to be
game.
very alert on all these small part. Yeah. So the measles needs to be MR, measles rubella vaccine. Right.
The MCP code, all these things will be there, no? I'm sure your MCP codes are distributed in the mothers, and they'll mention the vaccine dates and vaccine when it was given, etc. So you should always ask the parents whether you have the card with you. That will tell also about the functioning at the field
Because
level. Okay.
it may be measles because the child is 5 years old and it was given at 9 so it's possible. Still, you make it a point that it was measles or MR that I'm putting. Yeah.
Sir, it was measles.
No, I agree with you. Just I wanted to highlight this. Measles is no more available till now. So for this case, it's okay measles, but now also look at the availability of measles and MR. Yeah, okay.
Yeah, you're doing well, but this is to make you more efficient in presentation, getting more marks. Okay, Dr. Abhisha is very careful in mentioning all these points, not upset you, but encourage you to get more information. Yes.
Go ahead, please.
Yes, sir. So child was exclusive breastfed up to 6 months of age, and thereafter complementary feeding was started. So breastfeeding will continue up to 4.5 year of age, and sir now patient is full on family diet. Sir calorie deficit is 250 kilocalorie, around 14%, and sir protein deficit around 3 gram per day. In sir child weight is between 10 to 25th percentile, and height is between 10 to 25th percentile. BMI according to BMI chart. BMI is 25th to 50th percentile. So child is well built and well nourished.
So
sir.
one minute. Go to the growth chart. So whenever you plot the chart, you just make it a point. Do not encircle it.
Yes.
Encircling the point is not recommended.
Yeah.
Hmm?
Okay.
This is also very important, right? And second,
Very important. Yeah.
yeah.
Yesterday, Dr.
So-
Bala also was mentioning one of the case presentations in infectious disease.
yeah.
So many times, we find this, and circling is not allowed nowadays.
Even some of the
Okay.
endocrinologists encircle it,
Yeah.
but it's not
Yeah.
recommended
Yeah.
actually. It's not allowed.
Yeah.
And second
Absolutely.
thing, what is wasting and what is stunting? Very quickly, give the definition.
Sir, wasting is acutely loss of weight is presented with wasting, and this stunting, it is chronic malnutrition.
You're not
No,
audible to
sound
me, at
is
least.
not audible. Suddenly, voice is yeah. Till now, you're audible. Suddenly, voice has become 20% of the usual. Yeah.
Yes. Please speak loudly and closer to the mic.
Due to acute malnutrition, in that weight loss is present, and stunting is due to chronic malnutrition. In that case, height is also affected with
Yeah,
weight.
excellent. Very good. Very good. Yeah, please go ahead. Yeah.
So child was developmentally normal up to age, and is going to school and studying junior KG, and absolutely fine in study.
Developmentally and growth wise, you already shown the growth chart. So add that. Development is different. Okay. We are
But
talking about
he has
various
given the
and
growth
also
chart. So,
mention.
sir, it's
Yeah,
absolutely
that's
okay, sir.
what.
No,
Yeah, but
okay.
better mention both.
Yeah.
Growth and development are normal in this child. Yeah.
Okay, please.
Yeah.
Sir, on examination, sir, I have examined Pavitra with proper light and exposure. Sir, on examination, child was sick looking, lying on bed, and he was conscious, cooperative, and well oriented to time, place, in person. On examination, sir, temperature was 102 degrees Fahrenheit in right axilla with measured with digital thermometer. Sir, pulse rate was higher, 163 per minute, which was good in volume in right radial artery, measured in supine position. Sir, respiratory rate was 42 per minute, which was increased as per age of child with normal breathing pattern. So SpO2 was 97% on room air, and CRT was less than 3 seconds. BP was between 50th to 90th percentile on examination.
So, yeah, so here you mentioned that tachypnea with normal breathing pattern. What does it indicate?
Sir, tachypnea can be due to increase rise in temperature.
Yeah. So if there would have been any respiratory issue, it will be tachypnea with retraction. Here there is no retraction. The breathing pattern is normal. So it's because of some metabolic disorder or some high grade fever, something like that, right? Yeah. Okay. Go ahead. Yeah.
In general examination, there is no pallor, icterus, clubbing, synopy, and edema was present. So lymphadenopathy on lymph node palpation, there is an anterior cervical group of lymph node was palpable, which was 2 by 3 centimeter in size maximum, and which was bilaterally anterior cervical lymph node were palpable, which was non-tender, mobile, soft, and overlying skin were normal. In submental group, bilateral lymph node palpable, approximately size was 0.5 into 0.5 centimeter.
Can I make a comment about this slide?
Yes, sir.
Because you started presenting with symptoms of cough and cold. So is it not necessary to see the upper airway and this thing? Though of course you mentioned the respiratory rate, etc. you have straight away gone to pilar, icterus, clubbing, cyanosis, lower down. The symptoms are all pertaining to the upper, this, throat, cold, cough, nose and throat, you mentioned. And then lymph nodes in the cervical. So you have to mention about the, I told you just mentioned Kawasaki also. So you have to mention about the face first. Okay,
Yes.
throat you have to see, then only other things will come. Okay, am I correct, Dr. Abhaisha
Yeah,
and
yeah.
Raju
So
Katke? Yeah.
it's about
Yes, sir.
systemic
Yes.
examination from
Yes, sir.
head to toe, right? Yeah.
You may be mentioning subsequently, but what is important is because you have mentioned the symptoms and you start with the face. You always look at the face of the child, attitude, apathy. You said, child is this thing, apathetic and this thing, sick looking. So it's very important. You have to mention whether the child is active, general appearance of the child, active, alert, responsive to your this thing,
Yeah.
examination.
And
Okay,
facial
or
expression,
child,
facial
yeah,
features
yeah.
and finding, yeah.
Just a general comment about the attitude of the child, behavior of the child, and also the you start with head to toe. Yes,
Yeah.
thank you.
Now, yes. Now, this what is the importance of this? Which for inguinal region, axillary, and cervical region, what is the size of the lymph node that is significant that made you think that yes, this lymph node has a high suspicion and not the low suspicion? So, what is the size of the lymph node that you consider? It is same for all the groups, or is different?
No, sir, it is different.
Yeah. So,
In,
what is that?
For cervical lymph node size is more than 1 centimeter, then it is significant. In inguinal region, it should be more than 1.5 centimeter to be significant.
Yeah.
And in groups like subtrochlear, epitrochlear lymph nodes, if just palpable on 0.5 centimeter is also significant, sir.
Excellent.
Yeah, very good
Please,
point
very,
you have made.
very good.
Yeah. Only thing, one additional thing, epitrochlear is very important. Even size is not matter, but there must not be any skin infection in the hand and fingers, etc.
Yeah. So,
Yeah.
when the lymphadenopathy is there, what is the definition of generalized lymphadenopathy?
Sir, more than
More than? More than? Please be specific.
non-contiguous group.
No, yes. So there may be multiple lymph in the same group. It is not generalized, but more than 2 groups or the non-contiguous group, then it is a generalized lymphadenopathy. Yeah. Okay. Good.
Yes.
Go ahead, please.
The inguinal lymph node also palpable, 3 to 4 in number, and maximum approximately size was 1 by 2, 1 by 2 centimeter. In head to toe examination, the hair was black, thin, and there is no facial deformity or no facial edema. In oral examination, there were follicular tonsillar enlargement and congestion of tonsillar bed was present. So kissing tonsil was present. On teeth were normal in number and there is no caries. Tongue were normal in size with normal papillae, and eyes there is no pillar or icterus. Nose and ears are normal. Chest and abdomen there is no visual abnormality. In genitals also normal. There is no skin lesion or rashes on examination.
1 minute. So in eyes, some important thing is left. No pallor, no icterus.
No signs of conjunctivitis or
Yeah,
any.
that is also exudative as well as non-exudative conjunctivitis. If it is exudative conjunctivitis, it's a viral infection or bacterial, whatever it is. If non-exudative, it's some inflammatory response like Kawasaki disease. Second, ear, nose, everything is fine, normal, lymph node. Okay. Okay. No, you have not mentioned about this palate membrane.
Yeah, strawberry tongue and other things you have to mention.
Strawberry tongue
of course,
and about membrane, diphtheria, there is
Yeah.
no membrane.
Yeah.
So it is very important. Yeah.
So this is a child's photograph, throat photograph. Is it the child's pay? Yeah, describe this thing, the throat tonsils. Are tonsils important in a 5-year-old child? Are they enlarged normally?
No, sir.
The lymphoid growth curve, So they are the gateway, like a camera for finding out this. There to find out what organisms are entering the respiratory tract and gastrointestinal tract, etc. So they give the signal. So tonsils, the lymphoid growth curve. Okay. So Thymus is very big in newborn. Here, of course, is it normal or abnormal? You comment about the tonsils. If this photograph is the child's photograph, then comment about the child's tonsils. They are normal or abnormally enlarged?
So it was abnormally enlarged. It was actually grade 4 tonsillitis.
Okay.
More than 75% of the area
With
involved.
no membrane. With no membrane. Okay. Yes.
Exudation was present.
And otherwise, child was not having any adenoid phases or open mouth breathing, because of so much of obstruction is there. Whether child was having mouth breathing, any snoring was there? Did you ask the mother?
From
So
the
there is
Complaint?
snoring, but
from
there
the-
was nothing present since one day.
from the history and physical exam, can you tell it's a viral or bacterial tonsillitis? What is the Centros criteria?
Sorry.
Bacterial clinical
viral?
scoring criteria
What do you
for
think, yeah?
bacterial or
Sir, what criteria did
Yeah.
you?
please go ahead.
Dr. Raju Katke, you are keeping quiet, please.
No, sir.
More interaction.
No,
Yeah, thank you.
I'm listening that the things are going on right track.
Yeah, okay. Thank you. You are the gatekeeper. Yeah.
Basically, you said that our thorax as well as abdomen is normal. And previously, you explained on the history that basically there is abdominal distension in the child.
Hmm.
Chest and abdomen, no abnormality.
So,
No external.
so
No,
you have
On
mentioned
inspection. On
Abdominal-
inspection, I think.
Abdominal distension has been already said by the mother as well as
So,
you.
you
No.
said chest normal, abdomen mildly distended or some swelling at a particular site. You have to mention it. No, it can be seen even with the inspection as well. This is a very important point. There is a
Yeah.
disparity in your.
And you could have taken a photograph of the abdomen also. Whether upper abdomen, this thing, right side is this thing full or left side is full. Because, yes, okay, proceed. Yeah.
Then systemic examination. The child lies supine with hip and knee flexed and arm by side. On per abdomen examination. So inspection, there is fullness seen in left hypochondrium region. Breathing pattern were normal with abdominothoracic breathing. Umbilicum is normal, inverted, and there is no skin scar or no visible dilated veins and no peristalsis or pulsation seen on inspection.
Now you have mentioned the fullness in the left hypochondrium, no? With their abdomen, you have mentioned normal. So that's what it was asked the previous this thing, discussion. So having mentioned that, now you are mentioning, fullness in the left hypochondrium we have seen, but the previous slide shows that incongruency should not be there. Okay, yes.
And what are the possibilities now when there is a fullness in left hypochondrium?
So there can be two organ involvement, spleen or kidney. For
Kidney, unless it's markedly enlarged, you will not find.
It's not.
Okay,
So
and
mainly,
that to acute. Yeah.
So you can start from superficial dipper. It can be any localized soft tissue swelling. Child might have some, not in this case, it may be local hematoma, it may be a locus, some muscular swelling, or common is just splenomegaly in this case, right? Yeah.
Especially with lymphadenopathy and congestion and fever. So naturally, it is likely to be more of a splenomegaly. Okay, yes.
That is to come with the answer of splenomegaly. Yes, Dr. Raju sir.
What is the importance of child lying supine but hip and knee flexed? And by
exactly, yeah, very important.
What do you want to convey us?
So child will lie down in relaxed abdomen, so we can examine.
No. What you said is basically child was lying in supine position, hip and knee joint were flexed and arm by the side. So, which are the conditions where you will find that the child is flexing his hip and knee joint?
The acute pancreatitis, where a child will bend.
Any severe abdominal pain would give
Any abdominal pain, yeah.
Or marked this thing. So that's why I asked position, in the beginning itself, history.
I think she has mentioned that she she wanted to convey that they have examined the patient in this condition, in this position. It is
No,
not a
that,
posture. It is not a
yeah.
posture adapted to the patient, but this is how they
There
proceed
is
for
some
exam.
discomfort in the this thing, child's abdomen. That's why child is preferring this position. That's what you wanted to mention. Okay,
Yes.
good. Proceed.
Sir, on palpation, abdomen was soft, non-tender, and there is no guarding or rigidity was present. In palpation in the right hypochondria, there is a liver was palpable, which was 2 centimeter below right costal margin in mid-clavicular line, and which was soft, smooth, non-tender with rounded margin. In left hypochondria, there is spleen was palpable, which was moderately enlarged, 3 centimeter below left costal margin, and which was firm and non-tender on palpation. The bilateral kidney were not palpable, and there is no abdominal lump visible or no abdominal lump palpable, and no abdominal wall edema was present.
So it's
So
a
now to
spleen-
comment
it's
about
a-
the liver.
It's a splenohepatomegaly, right? Now, Dr. Sir
I
says
want to
comment on
know,
liver. Yeah, please. What
Sir, I
liver?
want to know from this thing, 2 centimeter in a 5-year-old child. Is it below the costal margin? Is it considered the hepatomegaly? You must say also right liver and left lower, no, below the episternum. Sometimes left lobe may be enlarged. Okay, so 2 centimeter up to 5 years is considered normal. Okay,
Yeah.
And you have
beyond
not
5
mentioned-
years, yeah.
Sir, and no, you have not
Yeah.
mentioned liver span.
Yeah, very important. Yeah,
I think
that
no
after
pe-
percussion she may mention that probably. Yeah,
Okay.
yeah.
Okay.
So it is
Anyhow,
not
I am telling you there is this thing,
splenohepatomegaly.
Yeah, span is important, but liver,
Yeah, it can be person. Okay.
is
Yeah,
within the normal limits, but of course left lobe might be in, so you have to mention both sides, and of course spleen is enlarged. Very good. Yes.
So it's a splenohepatomegaly.
Yeah.
Yes.
Yeah, that's true. Very good. Spleen,
Sir,
how much it has to enlarge before it becomes palpable?
The spleen must be 2 to 3 times the normal
Yeah,
size.
3 times its enlargement, because otherwise a small organ which gets enlarged means palpable means it is 3 times enlarged. Yes, good.
So in percussion, there is no shifting dullness or no fluid through the palpable, and sir, liver span was around 10 centimeters.
So it is not mentioned here. Okay. Anyway.
Sir,
Any
on
iliac lymph nodes? Any other lymph nodes in the abdomen which could feel or pain in the iliac fossa? No. It's very
No, sir,
important
no
because we
iliac
have to
lymph node
say
were palpable.
whether sometimes there may be loaded fecal matter in this thing. They may also be palpable. So it's very important you mention, because you said no lymphadenopathy. You must also look for external iliac lymph nodes, internal iliac lymph nodes, and I say okay, proceed.
So what is the cause of abdominal distension in your case? Abdominal distension due to what? Not organomegaly. So it is not the fluid, not the flatus, but it is the organ, right? Yeah.
Organomegaly,
Okay.
yes.
Yeah. Okay.
Sir, on auscultation, there is normal bowel sound were present.
Yeah.
In the respiratory examination, on inspection, there is normal rate, increased rate of respiration with normal rhythm, and sir, minimal effort with absent of nasal flaring. There is normal chest shape and symmetry. On palpation, the trachea is in midline with bilateral chest expansion is equal. Normal tactile local parameters, and on percussion, the resonant sound were all over chest, and air entry was bilaterally equal and clear.
And no abnormal breath sounds like snoring or this thing,
No.
that thing,
No.
adenoid phases, all these things. It's important in the general examination. Mention also again respiratory rate when you talk about respiratory examination. Okay, yes. Proceed.
In CVS examination, precordium is normal without bulge, and there is no heave or thrill. Cardiac size was normal on percussion, and sir, S1 S2 heard without no murmur was there. On CNS examination, child was conscious, cooperative, and well oriented to time, place, and person. Power tone and reflexes were normal in all 4 limbs, and all cranial nerve functions were normal on examination.
Good.
When you talk about all cranial nerves, let me know. Let me know how do you examine all cranial nerves? Let us
I'm
start.
sure you wouldn't have done that. I'm sure you wouldn't have done that. Yeah. So don't get into trouble, okay? Because examiners sometimes,
I
It's very
Olfactory
important.
कैसे देखा
Once
आपने?
you haven't examined, you should not comment. Okay, yes.
They say no cranial palsy
That
detected.
would be better.
All
better.
all cranial nerve means very
Yeah.
difficult. Even neurologists
Yeah.
cannot do that. Yeah.
Yeah. No, you will not be unnecessarily troubling a
Yes.
sick child, isn't it? You will not examine, especially where there are no symptoms.
There is no symptom.
Okay.
Yeah.
Yeah.
So in this child, so there is a fever, there is a tonsillopharyngitis or a sore throat, there is lymph node, there is splenohepatomegaly, right? So now,
Yes, sir.
what is the 4 or 5 different diagnosis this condition? Do not jump to the diagnosis. What are the 4 or 5 conditions we look with a apparently normal RS, CVS, and CNS, right? Yeah. So which system is affected in your case?
Lymphoreticular system, sir.
Reticular endothelial system or the lymphoretic. So it's a with fever, is it infective or non-infective? Infective. So the acute or chronic? Acute or chronic? Acute. So it's a acute infection involving lymphoreticular system or the right or reticular endothelial system. So now what are the different diagnoses? Which infection of acute causes this? Hepatosplenomegaly, lymphadenopathy, malaise, poor appetite. Please tell me.
Epstein-Barr virus, then
Okay.
then sir, other virus like cytomegalovirus, then
Cytomegalovirus, why you think of this thing, you know, the child is very acute. Okay, so it will not. You think of course, Epstein-Barr virus, we will consider as one of the important possibility. Yes, cytomegalovirus is not that common, but still, it will not present so acutely and with this thing. Okay, hepatosplenomegaly will be there. Okay, yes.
In the chat book, someone has mentioned, Dr. Sangeeta mentioned about typhoid. I think typhoid usually there is no lymphadenopathy, right?
yes.
And we do not have the large spleen. It's a moderate or mild hepatosplenomegaly. Yeah.
Yes.
Please go ahead. Yeah.
Then sir,
in case summary, there is 5-year-old, 4-month-old male child, immunized up to age, belongs to lower socioeconomic class, presented with complaint of fever, throat pain, abdominal discomfort, and swelling swelling in anterior neck since 3 days. On examination, there was generalized lymphadenopathy was present with hepatosplenomegaly and follicular tonsillar enlargement was there. So there, sir, differential diagnosis can be Epstein-Barr virus infection or cytomegalovirus infection and typhoid, and there can be tuberculosis.
No, tuberculosis, why you want to say in a normally growing child with such acute and the tonsils are not enlarged in tuberculosis. Okay, tonsillar tubercular is very, very rare. Okay, yes.
So there can be brucellosis or
malaria.
But
in malaria, lymphadenopathy is not that common.
Malaria, where do you get throat infection, tonsillar enlargement and all, and lymphadenopathy? So don't think of that particular thing.
See, basically now you are on the case summary. So you should basically correlate all those findings as well as the history and come down to some 1 or 2 plausible reasons for that. You can't go saying differential diagnosis of generalized lymphadenopathy, differential diagnosis of hepatosplenomegaly. That you can't go on saying like this. Otherwise, you would land up in trouble.
If you don't laugh at me, I will tell one thing. In this case, first, second, third diagnosis will be infectious mononucleosis, Epstein-Barr virus infection. Fourth, fifth, you may have think of 2 other conditions. Because first thing and the foremost with this type of presentation, you have to rule it out. So you will consider first, second, third possibility as unless proved otherwise, then only you'll think of other conditions. Am I correct, Dr. Abhaisha?
Yeah. Absolutely. Absolutely.
Yes.
Proceed, yeah.
Sir, we have done investigations.
No, one minute. Yes. No, you said go to the first slide, previous slide. Now
Yes,
yes, he's there. Now he will give his final comments. So you can remove this follicular tonsillar enlargement just for the sake of discussion. So there is a fever, lymphadenopathy, and splenohepatomegaly. Then what will the differential? And once you add this follicular tonsillopharyngitis, what comes in your mind then? So now let us discuss it that way.
With follicular tonsillitis, without follicular tonsillitis.
So follicular tonsillitis were present, so there can be upper respiratory tract infection.
No, if the child has no follicular tonsillitis, time being, let us presume that, and child has got this short illness of fever, splenohepatomegaly, and generalized lymphadenopathy, what are the possibilities that comes in mind?
Sir, with all these complaint and tonsillitis, most commonly we can think of Epstein-Barr virus.
Yeah,
Again, your voice is again low. Yeah.
it can be many viral infection can cause it, and out of it, some virus will have this tonsillopharyngitis, right?
Yes, sir.
Can it told about brucella. So in brucella, we don't get this tonsillopharyngitis. We can have hepatosplenomegaly, lymphadenopathy, that's something like that. It can occur in TB, but TB, the illness is not that short. Only 2 or 3 illnesses, so it's not feeling it, right?
Yes, sir.
And now it can be infectious mononucleosis because the child is tonsillopharyngitis because of the AB virus, but infectious mononucleosis due to any other cause can have that is fever, lymphadenopathy, and splenohepatomegaly. But the way, please, expert comment. Yeah.
No, I'm just listening because intermittently I heard, I will not knowing the detail, but I came to know what they have described. I think straight away, suppose if I ask some of the questions to the presenters, 5-year-old child, as you said, with the fever, suppose if I forget the throat pain and the hepatosplenomegaly lymphadenopathy, what condition will come to your mind?
So brucellosis.
What is the duration of illness?
Yes, sir. Brucellosis will be mostly chronic fever.
No, here what is the duration, total duration?
2 to 3 days.
So 2 days.
So
Only
2 to 3 days.
Yes, sir.
2 to 3 days, I will say why you are thinking for the Epstein-Barr virus, infectious mononucleosis. I'm not sure whether the child had any skin rashes.
No, sir. Child has
No, sir.
no skin rashes.
What was the, I will say, you said follicular tonsillitis. What do you mean by the follicular tonsillitis? What do we mean by the on examination, what you will get from which you can say that this is a follicular tonsillitis.
So,
Whether the tonsils were enlarged,
yes, sir. Tonsils
Have-
were enlarged.
having any membrane,
Sir, membrane was not present. Exudative secretion were present on the enlarged tonsil.
okay?
You have to describe angrily looking red, no? And
Yeah.
no, child was having marked congestion and follicles were seen. Different lobes were
Yes.
very well marked and almost obstructing touching the uvula, short of few millimeters. So bilaterally enlarged without specific membrane or this thing. Yes, non-membranous follicular tonsillitis.
Suppose for a moment forget regarding the tonsils problem. The child had the fever, child had the hepatosplenomegaly, and even the generalized lymphadenopathy, as you said.
It's
And if
more
it
of
is
splenomegaly than hepatomegaly, sir. It is
Yeah,
only
one
2
of the-
centimeters in a 5-year-old child. Yes.
Okay. So what other possibilities you will keep in mind? If there is no throat problem, if it is fever, as you said, sick looking child, what other possibilities you will keep in mind?
Sir, other viral infection like dengue.
Okay. With the dengue, you will be getting this lymphadenopathy.
No, sir.
Never.
Lymphadenopathy is not that common.
Okay. And
The
child
child
is sick.
started with cold, cold and cough, this thing,
No,
throat pain.
no,
So
here-
not common.
here I am giving them the another case scenario where there is no cough cold, no even the throat problem. Child presented with very high grade fever. Child, as you said, is toxic looking. There is the enlargement of liver and spleen, and multiple, even the lymph nodes are enlarged. What you will keep in mind? And suppose the child complains of some, even the bony pain, what the mother says that during the night time, child is complaining of some pain at the lower limbs, requires even some pressing from the mother. What you will suspect? And suppose
Sorry, sir, due to some network issue, we couldn't hear your question, your whole question.
See, basically what he is saying is if there is no throat infection or throat pain.
let me make the point clear if they have not heard. This child is having the high grade fever of some days of duration. Liver and spleen both are enlarged. Even multiple lymph nodes are enlarged. Child is toxic or sick looking. And your mother complains that the child is complaining of the pain during the night, particularly lower limbs where the child requires even the pressure.
I already mentioned, sir. They already mentioned this condition.
Malignancy.
Okay. I thought that's why I was
it has been
Yeah,
discussed.
they have mentioned in the beginning itself that is child doesn't have that. Yeah.
Okay. And suppose another child is having the fever, even some skin rashes which are very specific at the time of fever. Otherwise, the fever disappears even as soon as the fever comes down. Any other condition?
And which rash is known as?
I'm not sure whether this is also discussed by them.
No.
Okay. Suppose the child presence of, I will say 5-7 years, same age, started with only high grade fever. You didn't have any other cause, but gradually you got that, yes, the child is having the rashes, and mother specifically describes that the rashes are appearing at the time of fever. As fever comes down, gradually the rashes disappear, and every time it happens so. And then gradually you are examining that after 3-4 weeks, as liver, spleen are enlarging. What you will consider? And even some joint pain. Let me give the hint to you.
Sir, dengue fever.
Dengue fever. Suppose, anyway, they have the full liberty to speak the dengue fever. Now let us try to justify that why it is not dengue. And how the commonly presents with the dengue fever. You must have seen the patients. What is the commonest presentation of the dengue fever?
Sir, fever with body pain, body ache.
Yeah. And
weakness and fatigue.
At least we know that commonly starts with some viral manifestations. Fever, generalized malaise, body ache, headache, something like that. We do not know that whether it's dengue or some other viral. But suppose if it is dengue and goes with the further course, there may be some problem of bleeding manifestations because the platelets have come down. At the same time, suppose leaking starts, then as you said, the problem may start in the form of the generalized weakness, decreased urine output, or even gradually the fluid deficit manifestations should be there. These are the commonest manifestations, right? Now, here where I have given the symptoms, is it so that in the dengue fever, the rashes appear only at the time of fever and then the rashes disappear? It is not so in the dengue fever, right? So is there any other group of disorder? What I want to sensitize from you. And another point which I want to tell all the students, those who are attending, please keep in mind what most of the times you know the condition in the examination. Examiner is not going to ask you regarding that condition many a times a single word. On the contrary, examiner wants to assess you that such a patient comes, how you are thinking, what is your thought process in the various situations. Every time if you say abstent by viral, it becomes very clear that the candidate knows the case, but probably the examiner may not ask a single word of the abstent by virus. He wants to know how will you approach. Another way, any patient who has the fever of 3 to 4 weeks, only fever, and then the rashes, as I said, appearing at the time of fever, disappearing with the fever, That what we say very classically name. I'm sure, are you in the final year, MD?
Second year. Both of them
Second year.
second year.
Okay, so I think you may be the intermediate stage, but at the same time, you must have seen or at least heard this type of the rashes are called characteristic vanishing rashes or evincement of the rashes. In which condition this is the characteristic? Any idea?
Measles.
Where later on even these, later on you will get the liver, spleen, lymphadenopathy. You may get it. Any collagen disorder?
Even joint pain.
And later on the joint pain develops. Anyway, keep in mind that always there's some connective tissue disorders. We will have to keep as a one group of disorders in such conditions. Then you can justify whether in particular patient, whether it favors or does not favor. But broadly, you will have to keep all the possibilities in mind. Starting from these infections, common infections first, later on the uncommon infections, collagen disorders groups, malignancies, various. That I will say that should be the thought process. Even suppose this patient presents with a very high grade fever, very huge liver and spleen, particularly spleen, very huge. And even particularly when you are going for the CBC, there is the bicytopenia or even the pancytopenia. And patient, when I came in the history, that patient has come from the Bihar, migrated in Gujarat for some work. What can be the possibility you will consider?
Yes, put the answer in your mouth.
Yeah, I'm specifically giving the idea.
Yes.
I think these are the things that various situations, according to the patient, you will have to consider.
Yeah,
Patient has a
especially when
very
you are
huge
going-
spleen.
Especially when you're going for DNB examination, you may go to Delhi or
Yeah,
Bihar. There's some Calcutta, you may get a Bihar patient there.
exactly.
And,
Yes, sir
so,
said you will get this
That's why he
patient.
wants to tell you about this. Yeah.
You will get this patient. Some of the DNB, your center is at nearby somewhere, Delhi or even the eastern part of the country, maybe Calcutta. And the patient, they will keep from that area. And now patient has a very high grade fever of longer duration, very huge spleen. Liver is also enlarged. Some skin changes are seen. And even CBC suppose is showing the bicytopenia or even the pancytopenia. What condition you will keep in mind? Presenting with huge splenohepatomegaly. And let me give the idea. It's an infection, but parasitic infection. Now think for the parasitology.
Kala-azar.
Very good, very good, very good. So I think these are the things which you should keep in mind. Various conditions. Not I will say straight away, even this Epstein-Barr virus. Even here also I will say, why not the even simple other viral infections? So how, suppose if you have thought of the Epstein-Barr virus, how will you proceed further? What will be the characteristic of spleen on examination?
On examination, so spleen was soft, non-tender, and with the smooth border, smooth
Okay.
surface.
You have said firm, spleen. Go to the slides, you'll see.
The spleen was
Yes.
firm, non-tender, and so it was 3 centimeter below left costal margin.
You said firm.
Now, on the contrary, suppose if you are thinking
Yes.
the Epstein-Barr virus, what type of the spleen should be there? Commonly. What type of the,
Sir,
what
sir,
will be
spleen
the,
is
come on, anyway.
sir, spleen is moderately enlarged. So moderately enlarged spleen, most commonly it will be firm. And if it
My
is soft,
question is, if I ask you the direct question, that suppose in a case of Epstein-Barr virus, if you are thinking commonly, I think always in the medicine variations are possible. But commonly, what would the consistency of the spleen? And therefore, even suppose if you are thinking for the Epstein-Barr virus, what precaution you will take while palpating the spleen?
sir, in Epstein-Barr virus infection, there is most common
Yeah.
spleen tend able to rupture. So if there is soft spleen, there is more chances of a splenic rupture.
Please remember, mostly absent by virus, spleen will be very soft. And even so soft that even handling is not proper during the palpation, rupture spleen has been deported. So that's the point that what we should keep in mind. Right. Why do you say it's smooth and something? Well, how will you say that this is a spleen only and nothing else?
Sir, if there is on palpation, upper border was not palpable.
Very good.
And sir, it was not ballotable on the bimanual palpation. And
Absolutely good.
Sir, it enlarge towards the umbilicus,
Right.
not in lumbar region.
Right.
And,
Any characteristic from which you can say this? Yes, this is the only
sir,
nothing.
splenic notch can be palpable.
Notch. Yeah. So I think these are the points which you should know, and these are the things which examiners are going to ask you in the exam. That how will you do? Right. All the points to be asked and to be kept in mind. Anyway, I think you can go further.
Yeah. Thank you, sir.
About the
For
rash,
investigations, I think
about-
investigations. Yes, yes.
about the rash, which he said about 2 to 3 weeks of fever in a evanescent rash and organomegaly, what he was pointing towards a collagen vascular disease like SOJI.
Yeah.
The answer has been given now for you. Yeah.
Thank you, sir. Thank you, sir.
Yeah.
Sorry, first I would like to know the names of those the presenters. I'm really
Yeah.
extremely
Among
sorry.
the examination, 4 examiners will be there. Will always be one examiner who will give some clues. You must be able to take the clues.
Yeah.
Yes. Yeah.
Come on. Now, whatever you are, go further. Go further.
Sir, we have done some investigations on CDC examination. There is a HK is 10.7, so mild anemia was present, and MC was 77, hematocrit 32.5%, WBC count 19,000 per cubic millimeter with lymphocyte predominance, and there was moderate anemia with reactive lymphocytes seen. SGPT was normal and bilirubin was also normal. So electrolytes were normal in range. There was a swab for KLB was done, which was negative, and no gram-positive bacilli. Resembling Corynebacterium diphtheria was seen, and no metachromatic granule were seen. Sir, dengue NS1 was negative. Sir, USG was done.
I think before that, come on the first slide, and I would like to your name, please, presenter.
Yes.
Sir, my name is Dr. Mansi.
Mansi.
My name is Dr.
Yes.
Dhruvi.
Mansi and
Dhruvi.
Dhruvi. Okay. Keep that slide on the investigations. Make it full
Yes,
screen. Mansi and Dhruvi, please remember, as an undergraduate student, suppose if you are reading, then you will put all the figures. That hemoglobin 10.7, count 18,000 something. But when probably as a postgraduate we are presenting, put your interpretation. Figure is not important. Suppose how here you should put it, that hemoglobin is showing mild anemia, leukocytosis with lymphocytic reaction, and peripheral smear shows even the reactive lymphocytes. Now, anybody will explain me that what is the reactive lymphocyte? What do you mean by it? Mansi?
Sir, reactive lymphocytes are this acute condition where a lymphocyte tends to proliferate, and
many a time they say even different type of the things, reactive lymphocyte. Sometimes they say the atypical lymphocyte. What do you mean by the atypical lymphocyte? I think before that you should know what is the typical lymphocyte. How the lymphocytes will be looking. How will you describe?
Yeah, because atypical lymphocyte must be described.
Yeah, first you should know the typical.
Diagnosis.
First you should know the typical lymphocyte.
What is
How
mononucleus?
much it covers, how much cytoplasm it covers, the nucleus. and this thing. So what is atypical about infection?
And then how will you differentiate what sir said? How will you differentiate from the typical to the atypical lymphocyte? Reason is, why I'm asking, many a times probably if you find that feature, that will help you a lot. That become the important clue for reaching the diagnosis. So always after this our clinical diagnosis, try to locate very important clue in the investigations. Sometimes your investigations, confirmatory investigations also may not be positive. But if you
taken a
gather
picture of the slide,
yeah,
have you taken a picture of the slide? Peripheral smear picture?
no, sir. I am
Of
sure it may
lymphocytes.
not be.
No,
It may
sir.
not be there.
Yeah,
Please
okay.
remember, Mansi, lymphocyte atypical are larger in size, and
Yes, sir.
even the nucleus is larger. Almost it is occupied, and cytoplasm is scanty. And it
Yes,
should not be
sir.
mistaken as the blast cells. Sometimes even suppose pathologist is very young, may not be supposed accustomed. The atypical lymphocytes may be wrongly interpreted as blast cells. So you should be able to differentiate. And atypical lymphocytes can be present in several viral infections. Common Epstein-Barr virus, but can you say some other viral infections where you will get the atypical lymphocyte? Any idea?
Bacterial infection.
There are 5 or 6 conditions where you find it.
Yeah, but in the exam never say 5 or 6 because you will remember
Hmm.
only 2 and then it
But
becomes difficult.
so you remember what is other than EBV?
Abhay is giving us the idea, but in the exam,
Yeah, something.
Yeah, you should
It
not
starts
take
with
numbers.
P or WC.
yeah.
I'm giving you a clue as one of the examiners. It starts in P or no. The condition is called WC. The coughing condition. It's coming back. This, but in spite of vaccination, no, it's coming back. That's why they have changed the type of vaccine given. I have given 3 clues.
I think more than sufficient clues to reach the identify the condition. Anyway, please remember other conditions like the cytomegalovirus can also do even this type of the atypical lymphocytes. So otherwise, even hepatitis A can also occasionally you may get the atypical lymphocytes. So several conditions which probably we should not be mistaken. Pertussis can also give rise to yes.
Varicella and even toxoplasma.
Yeah. Even here, Mansi, you have mentioned bilirubin is normal.
Yes.
Sorry, is it right? Yeah, normal. But is it possible in
normal.
Epstein-Barr virus that bilirubin may get altered?
Usually hepatic enzymes are altered rather than bilirubin. Means jaundice
but
is less.
Suppose in one of my cases, bilirubin was raised, marginally raised, and that is indirect type. How I will explain? It was a pakka diagnosed case of Epstein-Barr virus.
So there is
Is it possible?
Your voice is little low, please.
So mild jaundice, indirect type
audible,
of jaundice.
Yes, sir.
Sir, am I audible?
Yes, sir.
Yes, yeah.
Yeah.
So Dr. Prajapati sir is giving you hint, mild jaundice, indirect type. So what process is going on in the body after EBV?
hemolysis. Hemolysis.
Okay.
Which type?
Anyway, here you have not taken the photograph of your patient. Have you taken, Mansi?
No, sir. Photographs were not taken.
Okay, I'm not sure, but was there puffy face?
No, sir. No, there was no puffy face.
Suppose in another patient, it was puffy face. What is the explanation? I hope that you must have read the 21st edition of Nelson with this case. Have you read it today?
Yes, sir.
Mansi,
Yes,
have you read it?
Yes, sir. Yes,
Then,
sir.
Then I'm sure that they must have mentioned the puffy face. Is there Is there or not?
No, they said face is normal, except
Yeah, no, not
lymph
in
nodes.
this, but in this particular case, I'm asking. But I'm sure that if we read the Nelson, they
Yeah.
mentioned that even there may be the puffy face,
Puffiness of face.
and the explanation that why there is a puffiness of face. Is there any explanation? Many a times, on the contrary, that misguides the clinician, and therefore it becomes even the late diagnosis. But this is known. Anyway, the indirect bilirubin may be due to the hemolysis or even the rapid turnover of the cells. And therefore, even LDH also you may get raised. I'm not sure whether have you done in this patient or not, but this is also known. SGPT, yes, mild, even maybe enzymatic reaction is known. Okay, what other investigations you have done? Please go ahead.
So USG was done. USG, there were multiple variable size lymph node noted in the neck at level 1B, 2, 3, and periglandular around bilateral parotid, interparotid region, where largest lymph node is measuring 3 by 1.5 centimeter in level 2 lymph node, and all glands were normal in size, shape, and ecotexture. On USG abdomen side, there were splenomegaly was present, and which was 10 centimeter long. And sorry, Epstein-Barr virus IgM was done, which was more than 160, which was positive.
Yeah, use the abdomen also should mention about the liver span, because you have mentioned hepatosplenomegaly. I said that 2 centimeter with for normal for this child. Okay, so ultrasound abdomen not only for spleen, because you have mentioned any child with hepatosplenomegaly. So liver size is normal. Usually spleen is the most important organ which gets enlarged, preferentially in infectious mononucleosis. Yes.
Yeah.
Yes.
Yes.
Whether have you done the sonography of other regions, or I'm not sure clinically whether axillary inguinal nodes were palpable?
Yeah, they are
Yes, sir.
proper.
Yeah, that's
Yeah.
what they have mentioned. Yeah.
And Mansi, now retrospectively, I will say, forget regarding the Epstein-Barr virus, it's a case of lymphoma. I will say it's a case of lymphoma. Lymphoma can have the fever. Lymphoma can have the
Yes.
generalized lymphadenopathy. And lymphoma can have the liver and spleen also enlarged.
Yes.
Suppose if I have not done this Epstein-Barr virus IgM, I may call it the lymphoma. Is it right or wrong?
So in peripheral smear, actually atypical lymphocytes were present, so it can go against lymphoma.
For your kind
No.
information, peripheral smear may not help for diagnosis of lymphoma, because as you said, blast cells may not be there in the peripheral circulation. In leukemia, yes, we are expecting. Occasionally, even leukemia also can be even without the blast cells, may appear later on, or maybe only bone marrow. So I think absence of blast cells does not exclude the diagnosis. At least it is not there, that much you can say. Okay, what is this VCA? You said Epstein-Barr virus, VCA IgM. What is that VCA?
Sir, virus antigen.
Capsid.
Viral capsid
Viral
antigen.
capsid antigen.
Sorry, one person.
It is a capsular antigen of Epstein-Barr virus.
Where is the capsule will be there? In which type of the organism? Capsule will be there in which type of organism? Whether this capsule will be there in a case of virus. On the contrary, if I remind, that's why purposefully I asked the question. Capsule can be there in a case of meningococcal.
Bacteria.
Capsule can be in a case of the typhoid. Capsular antigen we are using as the vaccine, right? But here capsular polysaccharide organisms usually they are having the capsules, right? What is this here? They don't have the on the contrary cell wall. Viruses they don't have the cell wall, and here it is capsid.
Capsid.
So it is viral capsid antigen IgM. IgM is the antibodies against this antigen. So many a times I think we should know all the, but what was the another test which we were using when these antibodies were not available? Any other test in the past?
Yes, sir. Heterophile antibody test.
Okay. Which will be, I will say, which will be my, all these facilities were not available in the past. And therefore, as a clinician, we derived some of the points which will be the important clue.
Dr. Baldev can mention also about the name for the test.
Yeah.
Paul
Therefore,
Bernal test, am I correct?
yes, sir. Yes,
I've
sir.
forgotten. Yeah.
Actually, what I want to ask another thing, that suppose I was not knowing initially. Patient just presented to me with just fever only. And even I consider that is a bacterial infection. As you said, the throat infection, something. I prescribed some medicine. And next day the patient came with a skin rashes. Does it give me some important clue for diagnosis of some condition?
Yes, sir.
I hope you have got my question.
Yes, sir.
Okay, which drug the clinician might have prescribed?
Amoxicillin, sir.
So the point is, sometimes directly or indirectly, you are getting some clues. And with the reference to suppose medicine, if I ask you some more questions, which are the other conditions where indicated or without knowledge, suppose somebody has prescribed the medicine, which precipitates a condition and you are able to diagnose. Can you give some illustrations? As you gave over here, that fever, viral infection, give the amoxicillin and the appearing of rashes. That becomes a very important clue for the Epstein-Barr virus. Similarly, other conditions where knowingly or unknowingly somebody has prescribed the medicine, the condition is precipitated or some very important clue for the diagnosis. Can you give some other examples? Where medicine is given and the problem developed. And I said, oh, now this is diagnosis. Come on.
It is related to some skin rash.
Penicillin in syphilis patient.
That's not the important clue because that is a diagnosis. And then Herxheimer reaction developed, that is a different story. What you said is a Herxheimer reaction.
Yeah.
I hope that first you should be able to understand my question. That something was going on. Person has not diagnosed, prescribed some medicine. That medicine precipitated some symptoms or some important clue. And then it becomes very important point for me to catch the diagnosis. As here you said, that's why in the reference to that, I'm asking the question. Fever, if you give the amoxicillin, rashes, highly suggesting Epstein-Barr virus, like that. Suppose there was a patient of pain in abdomen. Somebody prescribed some medicine, precipitated severe abdominal pain. Pain was, I will say, intermittently, episodic, going on since long. I understand that the second year, if you have not read or if probably not discussed, you will not be able to diagnose. But have you heard the porphyria?
Yes, sir.
In porphyria, which medicine? Now I will ask you the question another way. In porphyria, which drug will precipitate the episode of the pain in abdomen? Phenobarbital. Please remember. Phenobarbital. Now, here another 4 to 6 weeks old male child was there. Healthy and hearty without any complaint problem. About 4 weeks, male child. Only breastfed. No problem. And somebody prescribed one antibiotic. And that condition is precipitated. And now it is diagnosed with some obstruction. Which is that condition? It was male child, about 4 weeks, healthy and hearty, having some mild problem like viral, and somebody unnecessarily prescribed, even I will say some antibiotic. Chalo, I am giving the one more hint. And the child presented to me with some symptoms, which become the very important clue that that antibiotic precipitated the symptoms and condition is diagnosed. It is an obstructive condition. It's a surgical condition. It is the upper GI tract obstruction. It is non-bilious vomiting. Patient present.
Hypertrophic pylori stenosis.
Yeah,
Yes.
congenital hypertrophic pylori stenosis, now precipitated by which drug? Precipitated by which drug? Which drug will precipitate?
Clindamycin.
No,
No.
we don't prescribe the, I will say, this is not uncommon drug. This is not uncommon drug. People are prescribing very commonly. That's why I'm asking you.
Overuse
But,
rather.
But I want to give you some time to think rather than to give the answer. Always, I will say we should stretch our neurons so that we can remember. Okay, it is a antibiotic. Somebody has given for some skin infection. 1 month-old child. There is the macrolide. Please remember. Azithromycin or erythromycin, if you are given macrolide, can precipitate the hypertrophic pyloric stenosis. So what actually my idea that many a time, please remember that these conditions will give the important clue, which probably nobody has thought of. Just incidentally you come across and you diagnose. Similarly, it happens with Epstein-Barr virus. From that, I got some ideas. Anyway, you have any other presentation further? I think before we go further, any comments from any expert? Abhay Bhai, sir, Srinivasan sir, Khatke sir, please.
Dr. Abhay sir, please.
Yeah, no,
And
sir.
of course, I want, of course, Dr. Raju Khatke also was little silent. I want to listen to him also.
Yes,
No,
yes.
When
No,
Baldev
no.
when
No.
Baldev sir is speaking, you just are stunned.
That is, of course, we get mesmerized.
No,
He
sir.
mesmerizes everybody, but still, you know, yeah.
About the drug and rash, which you are saying, there is one thing which we should really tell them, that there is something which is called a dress syndrome, and which dress can
So
be.
I can ask the student what is dress syndrome.
Yes, sir. Yes, sir.
What
yes,
E
sir. Very
stands for.
important.
Yeah.
Who will answer? Sir has raised the question.
Of course, high fever and this thing will have even lymphadenopathy in this case.
Yeah.
So
Dhruvi.
and then skin problem can occur. Yeah. What is dress syndrome?
What is the full form of dress?
Yeah. Have you heard the name? First,
Same
let
thing
us
as the
come to
dress
that
we
one.
wear. DRE. Yes.
First, I will say presenters. Sir has raised the question. I'm sure somebody, and now not uncommon. We do come across.
Yeah, we have seen with anti-tuberculous drug pyrazinamide. One of my own classmates and school classmate had the syndrome. Then we had to find out which drug he has reacted, and then we had to stop and start some other drug.
Where are the presenters? Very, I will say, dynamic. Both the students are doing very well. Because their mentor, I know, Namrata. I hope that Namrata is there. Namrata, are you there?
Yes.
Dr. Mansi, can you stop sharing so that we can see you all?
Yeah.
Yes, I think now. Mansi, you can stop sharing.
Even otherwise, we are seeing them. Yeah, madam, other people can be seen there.
Mansi, you can stop sharing.
Yeah, it's better if you can stop that.
Yeah, so that we can see the other people in the gallery.
On the top, it will be there, red color. Stop screen share. Just press on it. Yeah.
Yeah, very good. Very good.
Aarti also can give her comments.
Madam, yes.
Yeah, she has been silent.
So I was listening to all of you, and I think the each and every slide and each and every word on the slide has been dissected by the all four of you. But I liked all the discussions which were going on. The students have done it very well, though they might have felt they have been grilled by 4 external examiners. But I felt as a fifth examiner, they did very well. Only thing what I like is would like to tell you all is after you present your case, which you did very well, always try to remember how Dr. Ambedkar sir always tells us what is the anatomical
Anatomy,
involvement,
physiology, pathology,
pathology, and
biochemical, yeah.
yes. So everything you all did it the same way, like saying that it is reticuloendothelial system, which sir, they all have told you that. So always keep that because that makes everything clear for you. Also the presentation, suppose this child comes to you 2 weeks later with the peeling of the skin from the palms and soles, then how do you explain that? And which are the conditions where you get children coming like this? And usually they will end up going to a dermatologist. Actually, they are your cases.
Yeah.
Yeah. So where do you get this? Child is otherwise quite normal. They just come to your OPD and they say, my child's skin over the palms and soles has started peeling. As a resident sitting in the OPD, what would you ask?
Any drug intake?
Okay, all right, drugs. So do you know any drugs which cause peeling of skin? Okay, I brought this question because of the case you presented.
Yeah.
How will you correlate this? Say same child comes 2 weeks later. Where do you get this peeling of skin? Smartly, you should say Epstein-Barr.
Epstein.
You presented the case here.
Yeah.
So it's a normal phenomena.
Yeah.
You don't have
Yeah,
to.
good that you brought this point. Yeah. Yeah. Otherwise, it's
Reassurance.
been missed. Yeah.
Otherwise, what happens? Many times people prescribe steroids.
Yeah.
So it's just reassurance. In the OPD, ask a history. Was the child unwell 2 weeks ago with all the symptoms which your this child presented today? And any other, you brought it as a differential year,
Yeah.
lot of dissection on it. But what is that other condition where there is peeling?
Yeah, exfoliation of the skin after the infection is controlled, which are the conditions. Yeah.
You mentioned it. There is some congestion of the eyes also, conjunctiva, lymphadenopathy, mucocutaneous involvement.
Only single lymph node affected.
Especially in the.
We have discussed in the first few slides.
KD.
Yeah.
This Kawasaki. Okay. So these two conditions, just remember, it's like the scoring points. Okay. You mentioned drugs, which is also true.
Even scarlet fever and even typhoid fever can have this exfoliative.
Scarlet fever is well known. Yeah. The scarlet fever was the commonest.
And typhoid, exfoliative dermatitis is quite common. Yeah.
Okay.
So both presenters were very good. I think you've done a good job. But some fine tuning as mentioned by Dr. Baldev, I think it will help you to score more marks. I'm also learning from him.
No. Really, I'm extremely sorry that.
It's nice that you could come back and
my
join us.
present was not there, but I thought that.
Sir, I am a regular learner from Dr. Baldev Prajapati on Tuesdays.
Very nice.
Abhay Shah was also very kind every time, when there is a ID meeting, he will send me this thing.
Yeah.
Sir, I remember. Yeah.
I think regarding the presenters, both they have done the very good, whatever I attended. But I think from the beginning, what sir said, please remember, never address the patient as a case or even the patient of some condition like antic fever or hepatosplenomegaly or something. I think which somehow it's our habit, most of our medical persons, but which is not good. We should change it.
And you also mentioned about growth and development in the history itself, because many people gave more importance for developmental milestones, but not for, you have to mention one word, because as my mother had 5 children, I'm sure she would have been seen. If the child has not been thriving well, she would have mentioned the history. So always make a comment. Okay. That makes, gets more marks because you're
And
seeing a child who is growing all the time. Yeah.
yeah, and even never say mention that the mother and she's I will say relevant information. She's always reliable.
Yeah.
Never say that mother is reliable. Every mother is reliable. On the contrary, many a times when we are not able to answer, our reliability is a question mark. otherwise, otherwise,
They'll
mother
never
is always
mislead. They may
reliable.
forget, but they'll never mislead.
Yeah,
Yeah.
that's very important.
And always try to elaborate symptoms.
Yeah.
With little more details.
I think what I will suggest to the students, always forget regarding the case.
Yeah.
Think broadly and then gradually come to your case. Then with every symptom, then put all the symptoms together. And then again go for the analysis that what is the likely condition. And then as already discussed that first the anatomy, that even here also that which part of the support liver, then try to define whether it is hepatocyte problem, it is a biliary tract problem, it is really portal venous circulation problem, or even the RE cell problem, Cooper cell problem.
Yeah, in this regard, I want to mention, sir, in this regard, I want to mention, here the liver has been normal only. So don't make liver as an important involvement here. Of course, it may be enlarged, but spleen,
I'm not talking here as a generally, I'm talking just giving the illustration. Suppose
I was telling, they have mentioned within a normal liver, they have mentioned this neither by consistency nor by size it was enlarged.
Yeah.
Yeah.
Even suppose respiratory system we are describing, try to define, is it an airway problem? It's a lung parenchymal problem? It's a pleural problem or interstitial problem? And involvement of each component is having the very characteristic. Try to derive, try to find out. And that will give, I will say, very important clue. Even some uncommon condition or some complicated condition will be able to reach the diagnosis very nicely. So I think that's a basic approach which all of us should learn and try to, I will say, make the efforts to reach the condition in with that way. That will be very important. Anyway, I think we'll have to end over here, sir. We should thank I think that was a good presentation that both presenters are there. Together they are doing. But please remember in the exam, you are not going to present together. Individually you have to present. And
they are second years. Their exam going students has already completed the exam, so they are new. So I thought let them do it combined.
No, but here
definitely, it's all right. Always
it's all right.
Two people.
Even they can present. They can present. Nothing is wrong. Nothing is wrong. And on the contrary, we should appreciate that.
Actually, in Tamil Nadu platform, every Saturday there is a PG presentation. 3 students participate. We have to give common marks for all of them.
Yeah,
there is nothing wrong in that. Yeah,
nothing wrong. Nothing wrong. Thank you very much, Nehal. I'm really extremely sorry. Probably due to this in between interruptions, I could not focus and could not give my 100% attention. But I'm sure that I will.
You have given 80%. You have passed.
Thank you, sir. Thank you very much. Thank you. Nehal, over to you.
Thank you so much. Thank you, Dr. Srinivasan sir, Dr. Khatke sir, and Dr. Abhay Shah sir for being expert here and giving good suggestions and all the expert comment to the students who are presenting. They will benefit them a lot on a longer way. And Aarti Kinikar ma'am, today your comments were also very nice.
Yeah,
and,
very good. Very good
like,
point. De-exclamation.
They were topping on the cakes. So thank you so much, ma'am.
No, we all learned. I learned a lot. Thank you so much.
Baldev sir is always there to guide us. Today also, whatever comes from the sir, now we are always learning. So it's ever learning process from the sir. Thank you, Mansi and Dhruvi. To be a second year and present is sometimes difficult on a confidence level, but if you see,
very good.
you will realize
very
that.
Well.
Yeah, you will realize that when you present, you feel confident.
Yes,
so
yes.
Even encourage your other fellow colleagues also to participate.
Yes.
Thank you, Clarinet, for providing this.
I think Nehal, before you end, I hope that Namrata is there. Let me appreciate Namrata.
Namrata
Being the
but yes,
mentor,
definitely.
being the mentor for even these two students, she has done the good job. And it
Yeah, they
reminds
have
me
been very
that
confident, always smiling, and no tension was there in the face. That itself is a success. Yeah, very successful this thing. That is how you have to go to the examination. You should not appear this thing, frightened.
Because-
Then the examiner will try to bully you. So it's better you keep a very confident face. Yeah, that's also part of the game.
it reminds me that Namrata was also a very good presenter.
Hmm.
Very
The
good.
She is
teacher
a
of these
student,
two
sir.
students.
Yeah. So students are appreciated.
Thank
So
you very
thank you
much.
very much,
Thank
sir. All three experts. Special thanks to
I am
Rajiv
not
sir and
expert. I am
Abhay
a
bhai,
learner from Dr. Abhay
for
and
devoting the
Raju
OPD
and
time, sir.
Prajapati.
Thank you for the
Then-
opportunity to me.
Yeah,
I
yeah,
think
both of you have a
Thank you.
OPD, we know.
Yeah.
And Srinivasan sir from the abroad, he's also joined in the time.
Thank you, sir.
Some time zone difference is there, na, sir? And Baldev Prajapati sir, already morning, sir called me, Yogesh bhai, I will be traveling. Sir, even though he joined, he could join, sir. Thank you, sir. Thank you. Aarti
Thank you.
madam,
This is interest in teaching.
Aarti madam, now we have to take lead role. Huh? Nehal madam busy with her son and daughter.
All right, okay.
So now more cases from the Maharashtra now.
All right, sir. No problem.
Okay, thank you,
Yeah,
madam.
if you don't mind,
Thank
send me
you.
the link, madam. I will also like to
Yes,
listen
yes.
and learn.
Yes, sir,
Every
I will
time.
send you the link.
Yes.
Yeah.
we'll do
Nehal
that.
madam have a now
Dr.
number.
Abhay Shah used to send me all infectious disease. Very
Yeah.
particular in sending me. Yeah, I cannot forget that
Srinivasan
kindness.
sir is always part of the e-Gurukul since last 3 years.
Yeah.
21, 20.
Yeah, I have learned
Okay,
so
sir.
much in this COVID period. Yeah.
Oh, okay, sir. Thank you, sir. Thank you,
Thank
everyone.
you
Thank
very
you.
much.
Thank
Good
you.
night.
Bye.
Good night.
Thank you.
Night.
Thank you, everyone.
Thank you, sir.
Good night.
Thank you, everyone. Thank you
Thank
for
you.
sending
Listen,
us the
students,
opportunity to host
you
the
can do
session.
better. We are always
Say
a
my
learner.
regards to
Okay.
Vyas sir and the Sonal madam.
Okay, sir.
Namrata. Huh?
Yes,
Thank
sir.
you.
Oh, thank you, sir. Thank you.
Thank you,
sir.
Sashank.
Thank you,
I have
everyone.
another meeting 9 o'clock.
Thank you, sir.
Yeah, I know you mentioned that. Thank you.
Yeah. Okay, sir.
Bye.
Thank you.
Thank you, Doctor. All
Thank
of
you.
you. Thank
Thank
you.
you. Thank you.
Shashank, thank you, Clarinet, for
Dr.
providing.
Yogesh, thank you.
Thank you so much, ma'am. Looking forward to host you again.
Thank you.
Bye. Good night.
Bye. Good night.